Go ahead.
All right.
Yep.
All right. I'm Jacqueline, and we're going to talk about Duchenne muscular dystrophy. This is Debbie and Katie. All right. We do not have any disclosures, and our focus today is going to be on a case study because we want to know how to identify a patient with this. But I'm going to talk very briefly about the epidemiology and the genetic basis, and also Debbie's going to talk about what to do in primary care. So epidemiology, I asked all my preceptors, and none of them have a patient with this. So it's really rare, but once you guys hear the case study, hopefully you can identify these patients. The incidence is 15.9 to 19.5 per 100,000. It's usually more in Hispanic population and white population, and they see it in males more than females. There's actually a website called Save Our Sons for Duchenne, so that tells you that mainly it's just males, but sometimes you see it in females, but it's really rare. When they first discover it, the survival years were in the teenagers, but now they usually live to 24 to 26 years because now we can take care of their respiratory and their GI and their problems that comes with Duchenne. But before, they used to die very young. It was discovered by another guy that is called Edouard Marion in 1850, but the name comes from Duchenne, a physician, and he wrote about it in 1879. So that's why it's called Duchenne muscular dystrophy. But it was actually discovered by another guy. But he never wrote anything about it, I guess. I'm not sure. The genetic basics about it is that there's a mutation of dystrophin. And dystrophin, it results in Duchenne because dystrophin is the one that works with our muscles. And so the muscles are the muscles become weak because of the dystrophin. If you guys, I want to go fast in this because I really want to focus on the case study. But if there is a website, is for if you want to read more about this, is www.dmd.nl. If we want to know about how it happens. But the main problem is in the muscle fibers. It's usually runs in families. 2/3 runs in families. So if there is a family history when you're first doing an assessment, make sure you ask if there is any. Some of them are not gonna know, but if there is any problems with muscle dystrophy, and but unfortunately, there is new cases of the mutations. That is 1/3 of the cases. It's an X-linked condition, and right now we'll jump to the expression.
So the initial symptoms are going to include delayed walking, frequent falls once they start walking, and then difficulty running and climbing stairs. You're going to see hypertrophic muscles of the calf, pelvis, and thigh, and they'll appear noticeably bulkier than normal. It's actually not bigger muscles, it's more fat, but you'll see like a kid who has calf muscles and they look like a bodybuilder, an adult bodybuilder's calves. Progressive weakening of the muscles. There are also a variety of cognitive deficits that are associated with Duchenne's muscular dystrophy, partially because the dystrophin dystrophin protein does some things in the brain that they're still discovering, like all of the things they think it has to do with the structure of the brain. But you might find a patient who has delayed speech, who's not doing well in school because of cognitive deficits. And those are also just symptoms to keep in mind when you're taking care of patients, especially if they go with progressive weakening of the muscles. As the children get older, they start to have cardiomyopathy. Typically, by the time they're 8 to 14 years old, they're wheelchair bound. They start to develop complications as a side effect of being wheelchair bound, including scoliosis, more muscle contractures, and breathing problems. So we're going to go onto our case. So now we need the case pulled up. Usually the cause of death for children with Duchenne's muscular dystrophy is related to the cardiomyopathy. And it's usually in the 20 to 30 years old. Okay, so we have in our primary care clinic coming in a 2-year-old male who is white. And our question about this case is, how do we diagnose Duchenne's muscular dystrophy, and what do we do once we suspect it or diagnose it? So the presenting symptoms for this patient is motor delay. So he's 2 years old now, but he rolled at 6 months, sat up at 12 months, and walked at 19 months. So if you know about developmental milestones, each one of those is late. He has a speech delay. He's 2 years old, and he only has 5 words that he can say, and no family history of motor speech delays or muscular dystrophy. His vital signs are all within normal, no pain. For our physical exam, we found the cranial nerves intact, normal deep tendon reflexes. He has prominent calf muscles, spontaneous anti-gravity strength in all 4 extremities. He has a positive Gower sign when rising from the floor, and we'll show you an example of what that looks like, and a waddling gait. So the Gower sign is basically he's using his accessory muscles to stand up from the floor.
So after looking at this presentation, a couple of things that are relevant labs to obtain for a kiddo that has these presenting symptoms, in addition to his cognitive delay. Some of the characteristic labs for Duchenne's muscular dystrophy include obtaining an ALT and an AST, which are most commonly high in a kiddo this young, signaling the increase in the fat stores. We normally wouldn't see this in a kid this young, and we wouldn't be worried about fatty liver disease. So this would be pretty significant for us to look at. Another thing that's characteristic is the CKMB, or the creatinine, would also be high.
Like usually it's markedly elevated.
And that's, usually the primary indicator that they look at.
Is this creatinine kinase? Or, is this CK or is this
CKMB?
Not just plain creatinine. Okay.
Yeah, but it wasn't one of the things on the sheet. So
It's key.
Yeah.
Oh, okay.
Muscle.
Okay. Yeah, I was just shocked when I first saw 11,000 for creatinine. Okay.
Often what you might choose to do is order a TSH. Sometimes in congenital hypothyroidism, you might see some sort of muscle hypotonia or muscle weakness. And so ordering a TSH to identify if it might be something else going on is helpful. And then just showing that the metabolic screen was normal and his hearing screen was normal.
At birth.
At birth. So these things don't often manifest themselves right when they're born.
We can go back to
time.
the.
Which one? This one? That one?
No.
Is it that one? Okay, cool. So this is an example of sort of the Gower sign. What you would see in a toddler or a kiddo that's trying to get up because they are using their accessory muscles due to the hypertrophy that they've already experienced, which is kind of unusual for a kiddo. So we just wanted to show an illustration of that so that you can kind of get an idea of what it might look like in a clinic setting if you asked a child to stand up. And then just a summary of the labs that we would see. Does it? I'm good.
It's not working. Can you go to the next slide?
Maybe just click on it.
Yeah, you just have to click on it.
Yeah.
Oh. Okay, cool. So as a primary care provider, obviously the most important things are to identify this early, to diagnose this early, and then to do your best to maintain these individuals so that they have the best chance possible. And unfortunately, the outcomes are that they will eventually die from cardiomyopathy or other lung-associated conditions, but we have the potential now to try to delay those complications. When we were talking, we had read that there is usually a referral to a neurologist to confirm the diagnosis.
Yeah, because it's confirmed with a muscle biopsy or a genetic
test. So that would definitely be one of the first things that you would do so that you do have a confirmed diagnosis. And then as Katie was saying, your primary responsibilities are managing their nutrition. Their bones are going to be a lot weaker. We have to prevent them from obesity and being overweight just because of how their bones and how their muscles are really going to be operating in their bodies. So often a referral to a nutritionist or even having a conversation with a dietitian early on in managing a nutrition plan can be helpful, making sure that these individuals are getting enough vitamin D for that bone development, and monitoring those vitamin D levels are important. Cardiomyopathy plays a very big role as they tend to get older, so eventually a referral to a cardiologist. Guidelines are kind of saying 5 to 8 years old when they actually start developing those symptoms of cardiomyopathy and start seeing those cardiac changes is important. Scoliosis is another big thing that goes along with vitamin D, and unfortunately these kiddos are going to start being wheelchair bound at a period in their childhood, so we really want to identify scoliosis early and do treatments and management to prevent the severity of scoliosis, because as that progresses, these kiddos start to have greater difficulty with lung development and lung maintenance. And that is another complication. So we have heart complications, bone complications, and then lung complications. And often pulmonary function tests can be very important in their toddler years and on forward to ensure that they have adequate pulmonary function. There are different types of treatments and vests that kiddos can wear to help promote that pulmonary function and allow them adequate ventilation. So initially, we really want to address these issues and manage them, but we also need to know when to identify that we need to involve specialists and get them working on maintaining the best outcomes for these patients. Physical therapy, thank you. That's like the most basic thing. But yes, physical therapy is really important to kind of help prevent that muscle degeneration and the conversion of the muscle to the fat in these kiddos so that they can be as mobile for as long as possible before they do end up being wheelchair bound. There was some discussion about surgery, trying to prevent or repair contractures. So that's definitely a conversation that I think you could have with the family and kind of determine the severity of a child's limitations and decide if that's necessary. And of course, another thing that can be considered is steroid therapy with prednisone, which is usually started after the age of 5, according to some of the studies that we read, but there's obvious risk associated with that as well.
We have just a couple minutes left.
Okay.
I just wondered if anybody had any questions, because we have just a couple minutes left.
I just wanted to say that it really is like a team-based care.
Right.
With this condition, you're going to be working with a lot of different people. And one other really important thing is like counseling for the patient and for the family, because dealing with this diagnosis can be really devastating and it can be really helpful.
Also, I wanted to mention that there is 3 websites in the handout that you can provide to parents so they can get resources and services and more information about it. And yeah.
1 minute left. Any questions? Anything on the chat? No? Okay, well, that was a great presentation, a great case study. and it was a great echo. So thanks for participating, everybody, and we will see you in a week. All right, see you all later.